Welcome to TCNtalks, an Anatomy of Leadership. We continue our conversation in part 2. Dr. Joan Teno exposes the hidden problems with hospice ratings and quality scores. And now, here's Comeaux and Cordt Kassner.
You know, I find myself very excited about the direction that you're taking the conversation, which is if somebody calls you, or me, or Chris, or Ira, or whoever, right? And they say, you know, I'm in Houston and I need a really good hospice. Well, isn't it tremendous if somebody knows one of the 4 or 5 of us, right? But most people don't. Yep. And so I developed, and Joan, you and I have talked about this in the past and more recently, the National Hospice Locator, kind of along that same line. Like you were talking about star ratings, hospice visits in the last days of life, gaming, and an IPU. Maybe gaming is a penalty, maybe burdensome transitions is another penalty. So in the National Hospice Locator, I have like 7 quality measures, trying to add points to a hospice score. And I have 1 penalty, which is if a hospice has been indicted or convicted by the OIG, it's a penalty score. And as we're talking, I'm thinking, well, maybe I need to add another penalty score for the burdensome transitions and what that might look like, because this is a tool for everybody in the country to use to find a high quality hospice provider. And so I would love to talk with you more, as I do with people around the country. Are the measures I'm using the right measures? Are they weighted the right way? How can this be strengthened to help the public? Because that is the sole purpose of it. And right now, like today, the locator is calculating a quality score for every hospice. But one of the thoughts that I've had recently around integrating AI into the National Hospice Locator is for the user to input some, 5 questions. I don't know what the 5 questions are. Answer 5 questions of what's most important to the patient. And therefore, if the 3 of us are looking for a hospice in North Carolina, we might get different answers for what's the best hospice for me, for you, which is kind of an interesting. I'm talking with 1520 AI, which recently acquired Hospice Analytics. I'm talking with them about how could we develop such a tool, which could be fun. But all of that in reaction to the criteria that you use or other people use to determine a high quality hospice. I want to get back and poke on this issue of small hospices not having to report data, or Medicare not reporting the data they receive from those smaller programs. If that's a star rating, where only 30% or so of hospices have a calculated, publicly reported star score, or other measures, in my assessment, in the National Hospice Locator, that dings small programs that don't have data to report. And I say, in the fine print, that doesn't mean this is a poor hospice. It just means we don't have their data to report. How would you address this issue? How could we fine tune this for rural or even urban providers who are smaller?
Yeah, I think first of all, there's a lot to unpack here. So one of the first things to unpack is how do you weight all these measures coming together? Okay, I have now a 9,000 word chat with Claude AI where I'm sort of poking it to understand how it would derive weights. Okay, and I think the best starting point is to rely on experts. Okay, but I think future research needs to decide, just like some of the questions. Well, if a hospice is convicted of fraud, does that fall on them for 2 years? Does it fall on them for 3 years? Okay. I think there's going to be some measures that are going to need to be a flag. So I think gaming should be a flag. What to do with rural locations? I wish I had a good solution. But on the other hand, I think some of these rural locations are actually probably some of the best hospices. And really they're not my problem childs to look at. Um, you know, so I wish, I don't know, I have to think about it, but I think it's going to be exciting. And I share your vision. I really want a consumer to be able to write a prompt that says, tell me the hospices that are, 4 or 5 stars, um, good visits measure, has an IPU, or, maybe eventually we can get, that has a Portuguese staff or something, that's really important to them. I'm sure there are small hospices that serve very boutique or very um, private things that we don't want to penalize them. But I don't know if I have a good answer for you on that. I do want to point one thing out, okay? And I'm going to push back on a little bit. Um, I think, as I said before, there is not 6,970 hospices, okay?
Mm-hmm.
And that has implications for the statement that, 30% of them have star ratings. I actually think we're going to be more towards the 5,000 to 4,500 hospices. I've done sort of just a flow diagram looking at hospices that had an ADC over 15. And there was like a really old article from 10 or 12 years ago that's on the internet where you were at a conference where you talked about what's the viability of an ADC after 2 years. And, I think they were using a 15 or 20 range. I actually, for this just thought piece, I used 5. And, when you get down to 5 and say, okay, someone who has a ADC of 5 or is not reporting an ADC is really suspect. We're starting to get CAHPS reporting up to 42 or 43% of star ratings. I'm always struck by the paradox that 88% of the hospices have 88% of people who die on the Medicare hospice benefit is in a CAHPS hospice star rating institution. So, and then, there is this percentage of people who don't meet the inter-unit reliability for star ratings. Is there something that we could do where we could say, looking at the geography, here's how these small hospices perform in this region? I don't know. I think it's going to be a political decision, and it's probably way above my pay grade. But I really think more information is better. And one other thing I'll say is maybe what we really need to do is let people decide what information you want now. And then they can say, I want this level of information with this degree of certainty. Okay. And let them filter the data. I think the friend who I talked to on a Friday, trying to compare data and looking at 90 hospices is not a really viable way of choosing a hospice program.
Absolutely.
We just need to fix that. And I think part of it is you get reported on Compare. If you have one patient in that zip code, you get reported. So maybe we need to have a different threshold. But I think it's important to really ask the fundamental question. Why aren't people using the Medicare Compare website? Okay. And, I think, and part of it is just think about, there's a trajectory of people who have an acute on chronic, and then the family is like dealing with someone in the hospital and they're, days away from dying and they have to go to this website. So I think we need to do a better job of getting the information out to consumers to facilitate their choice. And I think I would side on giving them more information than less information. And then, I think we need to really clean up the Compare website. And right now they're flagging them for not reporting data, but maybe we should flag them for what is viewed as a sentinel event, or maybe we should flag them for what is evidence of gaming. There's a hospice with 90% of the patients with dementia. That's a little suspicious, if you ask me.
Joan, I could talk to you all day. I love this.
I'm going to be really fascinated to hopefully you share your journey with me where you go with the analytics. I know I'm going to push for thinking about a proof of concept with Claude AI and say, can I create a composite measure and can I improve the inter-unit reliability? Yesterday, I got as far with Claude AI based on the published data with 3 or 4 measures where I could combine them to get, an inter-unit reliability of 0.85. And then, I said, well, what if you add BT1? They said, well, it's really, Claude said it was only a minor improvement and it would probably be more better to think of it as a flag. So, but I think there's going to be a lot of political decisions, but I think the time is we have this wonderful set of data. Let's use it. Let's put it together, but let's make sure we do it in a way that's fair to the hospice providers. But I also want to make sure we do it in such a way that we maximize consumers' ability to make choices.
Well, one thing that I thought of, Joan, when you were talking about the rural hospices, we work with a lot of rural at Telias. And one time I had a board member and he taught me the Willie Sutton rule. And I'm like, the Willie Sutton rule? What the heck is that? And he goes, yeah, Willie Sutton was a bank robber. And they asked him why he robbed the bank. And he said, well, that's where the money is. And I think the ones who have done the not good are playing the Willie Sutton rule. They're going to the metropolitan areas where all the people are. And the vast majority of people in the rural area are doing the best they can with their scarce amount of resources to serve. So then the law of numbers is not exactly in their favor, and they're not fighting off a bunch of competition because the Willie Sutton rule is not in their favor. So you wrote about your interaction with ChatGPT. So you've had some great examples of great AI interactions. That's one in your Substack where you were trying to select a Rhode Island hospice. And it was fascinating because the AI sounded confident, but it was relying upon unvalidated, even some imputed, made up, hallucinating measures. So what does that experience teach you on maybe the opposite side of the promise, but also the danger of AI decision-making?
I think that the danger is just the fact that it's hallucinating, and not hallucinating in terms of sort of being on drugs and hallucinating, but it's creating information. And you have to, I think what I've learned from it is you always have to probe what the data sources is. And so like I just sort of in that interaction pushed back and said, listen, you can't do that. And, maybe what we need to do is have live discharges be an available information. I mean, right now, the tension of the HCI is it's a topped-out measure, but some of its components don't achieve sufficient inter-unit reliability to be publicly reported. Is there a way of putting it together and giving it less of a weight because it needs a bigger end to to get that inter-unit reliability that you could combine it and use it in information? And I think that's going to be the question for people who think about this in terms of psychometrics and see if there's a way of combining this to make it all work.
Kind of a similar question that Chris is asking, instead of like what's working, what's not working. I also talk with consumers, usually once a week through the National Hospice Locator, but also friends and colleagues who call or have questions about hospice. And I'll tell you one, I spoke with one of our people, right? A trained hospice palliative medicine certified nurse practitioner, like in our circle, who called me up and said, hey, my dad needed a hospice in such and such state. And so I looked and I recommended this one, and boy, was it lousy. And like, what do I do? Like, dad died. What do I do now? And so I started thinking to myself, are they accredited? You could talk to the AO. Are they, licensed by the state? You could talk to the Department of Health. You could talk to Medicare. I started going down the complaint road. But actually what surprised me was in less than 5 minutes of my looking into this hospice, my thought was, why did you pick that hospice? Like, it was so clear that the hospice that she picked would be right near the bottom of my list. But but she's in the field and she selected this one. And I thought that was so curious. And that's the question that I want to pose to you, which is, when you're talking with the public, not the policymakers, not the academics, when you're talking with the general public, what misunderstandings about hospice do you run into? that you'd like to correct? Like, well, they think this, but actually it's that.
There's two things. I think that's a really good question. So first of all these things that we public report are based on averages, and there's always variation around those averages. So, for example, you could have a large hospice that has 3 different teams, and it could be the one team that's based on ALS is not functioning well just because of that shared collaboration is not working. Yet you will not be able to sort that out in any of the compared data. Okay. So that is always a problem. You only can go so far with that. I'm always kind of surprised when people have difficulty trying to select a hospice program that they really don't look at the data. And I think, first of all, one of the experiences I had was where they actually just referred one of my friend's father to a hospice without asking her. And, I said, no, 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 no. You're the durable power of attorney. You have a right to have a choice made, and you need to, let's go through. And I just sort of walked her through the Compare website, and we came up with a hospice that was in the area of Massachusetts that eventually got the referral and things went well. But I think we need to make things a little more actionable. And I think it's the sophisticated consumer that's going to need to draw on multiple sources of data and think it through. I don't know. It's a good question. Yeah, it's the future of where we should be going, hopefully.
So let's maybe step back from some of the technical data, kind of get you out of it for a second. What concerns you the most about the current state of hospice in America? And you're at an interesting part in your career, Joan. Where do you still hope that the field can preserve its mission, but still address fraud, profiteering, and these measurement challenges? And, in many respects, this Dr. Bayok shared, he wrote his strategic framework. He said, I couldn't sleep at night. So he kind of had to get that thing out of him. And my guess is you probably have a similar affection, but also concern for our future.
So my concern is we're going to lose public trust. And I think some of that is already occurring right now. And that, and the reason I started the Substack was I just, Rhode Island is a certificate of need state, and they kept on approving the Health Council kept on approving another for-profit or private equity-backed provider for the state. And they weren't looking at their data. And, I've written several letters to various people, to the governor, to the person who's charged the health department, and making the argument that, listen, hospice is really what I call a constrained market. Okay. 2 things. One, short of a pandemic, the death rate is relatively stable. It's slightly increasing. But the second of all is the way we've structured the Medicare hospice benefit it is still viewed by a lot of consumers as a terrible choice. And, while people are, yes, I want to get my hip pain fixed, they're not knocking on the door to try to get into Medicare hospice. So I think that limits the number of people that you can have. And when you have an oversupply of providers, I think you end up with reduced staffing, lower quality of care, unethical enrollment practices, and you end up with hospices that are going from focusing on patient needs to patient recruitment. So I think it's really important that we, again, look at certificate of need laws and think about certificate of need very separately when there is a constrained or saturated market like hospice. I think the evidence is there. One thing that's really interesting to maybe circle back to the CAHPS reporting. California reports only about 8%. CON states are much more higher in the 50% range. And, I think, we want competition because I want everybody to be striving for excellence, but we don't want an oversupply that leads to really this sort of aberrant behavior where I think they call it, Tom Konsumkas and crew call it profiteering behavior, which I think is a really problematic. And I think that's the thing that if I think really saddens me is there are persons who are running hospices who think it's great to make a profit over not providing services. And that is really disheartening for me to see. So, I'm hoping that in this sort of data-driven look and hospice moratorium that we can start fixing some of those problems where hospices are just selectively enrolling only nursing home and ALF patients. They're not providing all 4 levels of care, or at least 3 levels of care. And I want to return some of the integrity back to it. But on the other hand, I don't want to lose short of the message that um, staff in hospice are amazing people. Each week I see this. And, one of the things we published a paper on the difference between for-profit and not-for-profit patients. And I was surprised it wasn't bigger. And I think the reason why there's not a bigger effect size on the CAHPS scores is the staff. I routinely hear about nurses who don't turn their beeper or their cell phone off at night. They take calls, they go the extra mile. And I think sometimes we don't cherish how hard these staff are working and how good their hearts are to provide care for this population. They're not the problem childs here. They're the ones that we should be really commending because they're doing a great job. I have no regrets about being a hospice medical director and really working with a wonderful group of healthcare professionals. And there's few things in medicine where you can work with a team, and hospice is one of those few places where you can work with an entire team. And that in itself is just such a joy to be part of.
Yeah, I love what you just said. I agree with you. And it's obviously why we do the show is for those people, is to be a resource to them. But they're doing amazing work. And then the other part, I feel like you've alluded to it, the model that they exist in is a brilliantly designed model. The holistic care, the IDG approach, the fact that we create a care plan to keep what's most important in front of them and keeps them focused. It's a brilliant model. And you were part of the group that created this thing.
Joan, actually not. Well, I'm sort of more of a second wave person, but hats off. The core group of people who did this was just an amazing group of people. For the hospice that I spent a lot of my time and I currently volunteer, it was a guy named Reverend Charlie Baldwin who created what was Home and Hospice Care Rhode Island, became Hope Hospice. He used to reach into his wallet and pay people out of his wallet in those first days. And those are the people that we really need to celebrate. They're the ones who took this really wonderful idea and translated it into something. Just think about it. Sometimes I can get down and say, "Oh my God, we haven't made enough progress," but in my lifetime, we have made a lot of progress. We have 53% of persons dying who receive some level of hospice care, and their family receives some level of bereavement support. So that's pretty amazing. Growth of palliative care has been fairly amazing. Do I wish we could have done more? Absolutely. Not being satisfied and always striving for excellence is something we should be doing.
Absolutely. I want to make sure, Joan, I may have misunderstood you earlier, but you quoted 80-something% of people still complete a survey. Is that what you said? Like actual patients served or patients that died?
So 88% of the decedents have CAHPS data, okay? Just give me 88% have star ratings, and it's 94% have CAHPS data. So there's a group of people who just don't achieve that, hospices that don't achieve that end. So we have this paradox of, a denominator, which I don't think, here's the sad thing is we don't know what the denominator is. Right now the denominator is set at the threshold of one bill and for CCN to say someone's a hospice. It's pretty easy to say something is a hospital because it's a physical unit. It's not that easy with a CCN. So I think we really need to clean up the denominator. And as much as I love MedPAC, I would point out to MedPAC that the number of hospices, and they actually say this in the report, is not really equivalent to access, because I really believe that, I'm going to stake my bet. I think we're going to be around 45 to 4,600 hospices by the time that CMS gets through with looking at all these and sort of doing their work on suspending some of these hospices that are really ghost hospices. I think already in LA, the figure is climbing towards 1,000. So I think the denominator is going to go down. Now, the problem is these hospices are submitting fake data. And so that affects utilization-based measures. What's interesting to me is it doesn't impact CAHPS data, okay? Unless they are totally not sending the surveys out, but or not giving the vendors the right depths, but that can be checked. So I think CAHPS data still has integrity. I have concerns about utilization data, such as visit data, can be faked. The BT1, the burdensome transition measure one, probably can't be faked because it involves a hospitalization. So it's going to be interesting to unravel all this.
Well, two more, and then I'm going to hand it to Cordt. And so I think I've asked you this before, but the CAHPS survey itself, we can rely upon the questions. You've spent a lot of your career crafting that survey. I've always had just a niggling concern. Do we have the right questions in there that we really do know what drives satisfaction?
First of all, it's not me. It's a wonderful team that ran a really group of folks who I get a joy of being on conference calls with, Rebecca Enheim-Price, Melissa Bradley, just to name a really wonderful group of people who have crafted it. These are survey methodologists. I get to listen in and occasionally be a pain in the ass. But I do think it is. I think my one concern is as we make changes to hospice. So let's say, for example, there's several laws right now that are focusing on high-cost palliative procedures, okay? Does that mean we need new survey items, okay? What happens if you implement a policy, and this is just hypothetical, but you can have 10 dialysis sessions, and that's it. Well, do we really need a question around coercion and decision-making? Right now, that question would not have the signal to differentiate that. But if we change the policy to around how we deal with high-cost palliative treatments, do we need a whole new set of items around decision-making?
Well, and this leads to my last question, which unfortunately it's a big one. I don't know how you want to answer it, but you alluded to we've kind of hit this ceiling of sorts of percentage of patients served. I'm starting to see multiple schools of thought. I've kind of crafted them into three, that there's kind of a school of thought of high quality hospice and palliative care chassis together, maybe palliative care reimbursement. We've been working on that for years. Another school of thought I would call more of a vertical integration strategy, where you create a narrow network, home-based primary care, palliative care, and hospice. And then the third strategy, I would say, is kind of vertical integration, but those lines get erased. And some kind of way through multiple iterations of advancement and payment, maybe you get like a PACE without walls reimbursement, where you get the capitated rate. You manage the clinical care pathways for right care, right place, right time. And maybe that word hospice goes away and it's referred to as advanced illness management or serious illness. I feel like you kind of alluded to maybe tipping your hand but I don't want to read into it. So
I think you're raising a really good question, and I'm gonna give you some data back. Okay, so we have this sort of notion of to elect into the Medicare hospice benefit, you have to basically state my focus is now solely on comfort. Okay. And you lose access to some palliative treatments. Okay. Which could be beneficial, like blood transfusions, weaning off of dialysis. And that part of it, I'm really impressed. I've looked at maybe 15 years worth of data, and the median length of stay is a flat line. Okay. And I think a lot of it is a flat line because of the way we structure the benefit. But interesting enough, in countries where they have not this sort of what I refer to as a terrible choice, it's only 4 or 5 days more.
Wow.
Sure.
I just think we have to remember that there is a group of people who are going to be in this category, which I affectionately call "hell no, I won't go." And we saw that in the Medicare choice model. We saw there was a group of people who stayed on Medicare choice, who basically died on MCCM, or they transferred to hospice in the last 3 days of life because they were no longer making the decision. So I think there's a sizable part of the population that's never going to enroll in hospice. I'll give you one more data, and I can actually give you the reference. We interviewed from 8 hospices across the country. We interviewed 100 family members about the choice of hospice when they had a 7-day stay. And there's a good portion of them that said basically it was about the right time. And of those people who said there was about the right time, several of them refused an earlier admission. And then second thing, which I think is an important finding, is acute on chronic events. Okay. I can tell you I've taken care of cancer patients who are doing well, have a massive PE, and die a day later. I don't know if we would have predicted the massive PE. So, we're always going to have to deal with this disease trajectory. So I'm going to circle back one more time and say, what is the denominator of people who we can get onto hospice services? It's not going to be 100%. I think it's like, I think Rhode Island, which is last 2024 data, is 63%. I think we're getting pretty much topped out. Maybe we'll get it up to 70%, but I really don't see us, getting much higher. So I think that's, one of the things I see as a warning sign is you already have a fairly saturated market. You already have a lot of people on the Medicare hospice benefit. And you know what? People have choices, the medical director of St. Christopher was someone who I was a friend with and did a research project with, Bob Dunlop. And early on when I was still very young, back before all the gray hair, Bob taught me something that's really relevant. If the patient chooses to be in the ICU and die in the ICU, that's good. That's what they wanted. As long as they had understanding of what their options were and they made a decision based on their own values and goals, that's the way we should support them. So I don't think we're going to get 100% in Medicare. In terms of payment model, God, we need to do some work on that. I'm hopeful that we can get further down the line of concurrent care. I think concurrent care could work, but it's got to be the right payment. And I think, unfortunately, it's got to be a big enough hospice to do it. I think it really is hard for hospice with a ADC of 20 to do concurrent care, and how to do that from a policy standpoint. I'm not an attorney. Thank God I'm not an attorney. My sister is a judge. You don't want me to be an attorney. I don't know what the rules of authority are. And I'm sure, I'm the person who basically raised, why can't we count spiritual persons as part of the services we provide to hospice? And an attorney in the room said, you don't understand. There is a separation of church and state. But I said, I argued back, well, they're really providing counseling. Most of them are master's prepared people, but no, I got schooled on the separation of church and state by an attorney. So,
as I said earlier, I could continue this conversation all day. You're one of the most intriguing, fascinating, knowledgeable people in this area of anybody on the planet. And I think rather than taking 60 seconds and asking you 6 more questions, I'd rather take it and just thank you for what you have done, what you've done through your career, professionally, personally, how you have shaped end-of-life care. Very few things are immeasurable, but that might be one of them that is immeasurable. I just really, really appreciate you and your perspectives, and I just want to thank you for that. I don't know that we acknowledge and thank and highlight our heroes enough, but you're one of mine, and thank you.
Well, it's unbelievably nice to say, but I want to say I grew up with this unbelievable cohort. Okay. First of all, one of my best friends, Irene Higginson, every year I have the privilege of going to King's College and I have lunch with Irene and we just talk policy. And it's like one of the best conversations I have. Ira, amazing person. Diane, Sean, David Cassret. What a cohort to be part of. So, I think as I wrote in a previous thing, it really is a village of people that I've had the privilege of working with. And hopefully, I think I may have told you, but I have planned out my retirement, and volunteering and giving back and mentoring is key to my plans, in addition to traveling and buying more camera equipment and keeping my dog's vet bills paid are key as I sit here with a puppy at my knee bugging me.
And Substack is part of that plan, right, Joan?
Substack's my new hobby.
Okay, very cool, because I'm a huge fan of your
Thank
Substack,
you.
and I just want to echo what Cordt said. Again, you're one of my heroes as well, and just to get the opportunity to talk to you and share you with all of our listener base is just an incredible honor and privilege. And so thank you, and we're glad that you're going to keep giving back in all those ways, including the Substack.
Thank you very much.
All right. Well, to our listeners, we want to thank you. At the end of each episode, we share a quote, a visual. The idea is to create a brain bookmark. This one's going to be fun. A thought prodder about our podcast subject to further your learning and growth, and thereby your leadership. We want it to stick like a brain tattoo. Please be sure to subscribe to our channel, TCNtalks, Anatomy of Leadership. We don't want you to miss an episode. We're going to include a link to Joan's Substack and anything else she wants us to include. It's easy for us to rail against the world and be frustrated by things. Let's be the change we wish to see in the world. So thanks for listening to today's podcast. And here's our brain bookmark to close today's show.
We have the data now. Let's use it, by Dr. Joan Teno. Thank you, USI, for sponsoring this podcast.